Good afternoon, everyone. The topic for today is why I use Aflibercept in my cases of wet AIOCMT and DME. Myself, Dr. Anubhav. I'm a veterinary consultant at ASGI Hospital, Jaipur. This is my disclaimer. So we'll start with what factors drive the key mechanism behind the pathogenesis of wet AIOCMT and DME. So as we all know that VEGF-A is the key culprit along with other inflammatory mediators. It promotes vascular leakage, edema, causing inflammation and neovascularization. So even after targeting VEGF-A as targeted by brolucizumab and ranibizumab, there are other inflammatory mediators left which need to be addressed. So Aflibercept, it has a multi-target action. It's a decoy receptor fusion protein, and it takes care of all the accessory inflammatory markers along with placental growth factor, galectin, and VEGF-B. And these are the currently available and approved anti-VEGF agents available. So we all know that Aflibercept has always been a molecule of choice since past decade, especially in cases of wet AIOCMT in all of our clinical practice. We'll have some look at some famous RCTs and the real-world experience. So this is the data from Altair, which was a multi-center randomized open-label phase 4 study in treatment-naive patients. So at the end of 2 years, the mean changes in BCVA from baseline in 2 weeks treat and extend arm was gain of 7.6 ETDRS letters, and in 4 weeks it was 6.1. Although the number of injections was 10.4 in both the arms. Another interesting thing is the proportion of the patients which were maintained at 16 weekly intervals at the final visit in 2 weeks treat and extend arm was 41.5%, and in the other arm it reaches to nearly 50%, it's 46.3%. Second most important thing is in Altair, in the year 2, the number of injections needed was less than 4. So the vision gains achieved in year 1 were maintained to week 96 with fewer than 4 injections in year 2 in both the treatment groups. Another important aspect is in the 2-week adjustment arm, 43.1 patients were capped on 2-week adjustment, and after the finish of the study after week 96, 41.5 maintained that period. So up to 96.2% of the patients extended to 16 weekly Aflibercept maintained this interval to week 96 with Aflibercept, which shows the durability of the molecule. Some data from view-1 study, at the end of 2 years, there was 10.2 letter gain. In view-1, there was 8 weekly Aflibercept given. And there was an extension study period given, and the patients were prospectively analyzed after 3 years, and the name was given range. So range was a follow-up study of view-1 extension, and the vision gains were with Aflibercept maintained through 5 years with continued proactive dosing as per study protocol, and after 5 years, there was a gain of 7.1 ETDRS letters. So let's see what real-world experience has to say. So there was a real-world study by Al-Mutasib et al., and it was just a replica, or the results were a replica of view, because Aflibercept was given at 8 weekly intervals, and the results in terms of gain of ETDRS letters was similar to view, plus 8 letters gain was there, and 7 number of injections were given, which is exactly same as the view study. And the real-world experience from Moorfields and Jaggi et al., which was treat and extend regime, it replicates the result from Altair in the initial 2 years. And another important thing is when the Moorfield patients were followed for year 3 and year 4, the visual gain was maintained with the injection number becoming fewer and fewer in the consecutive years, which was 2.8 injections in the 4th year, according to the Moorfield data. Now, Aflibercept as a choice for diabetic macular edema, we'll have a look at the RCTs and the real-world experience. So the VIVID and VISTA study, there was rapid vision gains achieved with early intensive Aflibercept treatment in year 1, and the result was maintained to year 3 with a reduced number of injections over time. So at the end of year 3, in VIVID and VISTA, there was a gain of 11.7 and 10.3 ETDRS letter gain, and in VISTA it was 10.5 and 10.4. The point to note is that in the 8 weekly treatment regime, the mean number of injections given in VIVID was 4.5 in comparison to 8.7 in year 1, which is nearly half, and in VISTA the result is almost the same. So the patients from VISTA, after 3 years, there was a 2 years prospective study, and they were analyzed, which was named as endurance. So patients from VISTA maintained vision gains up to year 5 with continued Aflibercept treatment, and through year 2 of endurance, 25% of the patients required no treatment, and 48% of the patients received less than 5 injections in these total 2 years. We all know about protocol T, and it has already been established that Aflibercept is superior to ranibizumab and bevacizumab, especially in patients with presenting baseline acuity of less than 69 80 DRS letters or less than 20/40. After the 2-year period, there was a gain of 18.1 letters in comparison to ranibizumab, which was 16.1, and bevacizumab 13.3. The important thing is the median injections given in year 1 was 10, which reduced to just half 5 injections after the year 2. The slide's not moving. Okay. So let's have a look at the real-world data from Apollon. It replicates the data from VIVID study, and it shows that with early intensive treatment the first year, Aflibercept can achieve RCT-like vision gain, which was analyzed in year 2. There was a gain of 6.5 letters and with 11.3 injections. In Moorfields, the real-world experience, the patients from the cohort which was presenting visual acuity less than 20/40, in year 1, there was a gain of 17 letters. In year 2 and year 3, it was plus 11 letters gain. But the point to note is that in year 2 and year 3, there was a drastically reduced number of injections in comparison to year 1, with 7.1 injections given at year 1, 2.9 and 2.6 in year 2 and 3, respectively. So we'll compare with the newer anti-VEGF in our armamentarium with this with injection Aflibercept. So this slide already shown by Saurabh sir has been shown already. So there is no vision gain with faricimab were non-inferior to those with Aflibercept at the primary endpoint. This is a slide showing comparison with brolucizumab. In Hawker Harrier, only 39 to 45% of the patients were maintained on 12-weekly dosing with brolucizumab. One important point I would like to bring into notice is that being smaller in size and the higher molar dose being given, there is a very rapid effect, drying effect of brolucizumab is there. But despite the relatively high molar concentration of brolucizumab, its relatively small molecular weight means that it has a shorter intraocular half-life and it clears off early, and thus only 39 to 45% patients could maintain the 12-weekly dosing. This is the ocular safety profile, and we all know that brolucizumab has increased number of retinal vasculitis and occlusion cases. I would like to bring some clinical cases into you. Like this is the first case, a 60-year-old gentleman presented to an OPD serum DOV since 15 days. We can see that the right eye macular scarred, predominantly scarred CNV with subretinal heme, and the OCT is disorganized. The patient was given injection razumab, and after the first dose, somewhat the restoration of anatomy is seen with resolution of edema. The hemorrhage is gone. Even the vision was improved by significantly. Another dose of razumab, there was not much significant effect, no resolution of macular edema, although the hemorrhage cleared, but there was no visual gain improvement. So patient was switched to injection Aflibercept, and it worked beautifully. There was clear restoration of the normal foveal anatomy, and we can see the atrophied macula. There was macular edema drying was seen, no hemorrhages, and even the vision improved by 1 line. Patient was satisfied. In this case, this is a treatment naive case, right eye type 2 active CNVM. This is the OCT with lots of fluid. 1 injection Aflibercept, and the fluid dried beautifully with some pockets left, and the patient was advised another injection of Aflibercept. This case number 3, patient presented to us with right eye PD, already 3 doses of eccentrics being given. This is a pigment epithelial detachment which responded beautifully, and the PD flattened. After the first injection, there is some amount of SRS still left, but after the second injection, there was no sub-RP fluid, and even there was restoration of normal foveal anatomy, and vision improved beautifully. This is a case of moderate NPDR treatment naive patient, and he was given right eye injection Aflibercept. We can see subfoveal cyst, big cyst, and it collapsed just after a month, and the vision was improved, and we can also see there was some resolution of hard exudates too. This is the case 5, 60-year-old gentleman, poor glycemic control, deranged lipid profile, already being injected with multiple anti-VEGF injections, and this is a chronic recalcitrant case, just like any other chronic DME with big cystic spaces and small NSD. Patient presenting vision was 636. After first injection, the cyst collapsed, and NSD was gone, and there was a visual improvement. After the second injection, we can see the foveal anatomy being restored, and the cystic spaces, they collapse further. With further improvement, the patient is due for this 3rd dose. And this is my final case for today. 52-year-old diabetic female, phakic patient, PDR post-PRP, well lasered, no NV, 5 injections in the past year, Last given 1 month back, patient presented with this OCT, subretinal heme, big cystic spaces. Patient visual acuity was 660. After first injection, cystic spaces collapsed. And after second, they further collapsed. Patient is due for his third dose. Vision also improved. That's my time for today. Thank you so much for the patient hearing.
Dr. Anubhav, I think you have brought out very clearly the effectivity of Aflibercept or Eylea. But why I like Eylea more is because of its safety profile and maybe because of the schemes they offer nowadays.